Hello everybody, myself Dr. Sudipta Mukherjee, Critical Care Consultant from Tata Medical Center, Calcutta. And in next 15 minutes and so, I will talk about diagnostic dilemmas and management of pulmonary embolism in a post-operative patient in ICU. First, I'd like to thank the organizer for giving me the opportunity to present into this podium. Now, if you look at the data for post-operative pulmonary embolism, it is not that robust. This old autopsy analysis done on more than 25,000 surgical patients has documented 4,000 deaths, and it shows that in 11.5% cases, there are evidence of thromboembolism. And out of that, 5.3% cases, pulmonary embolism was considered as the cause of death. Now, if we look at our subgroup of patient, that is gynecology patient, this recent study had done on 2,100 post-op patient has shown the incidence of PE is around 2%. But what is more alarming is that out of that, 35% cases are asymptomatic, and in 93% cases, it has happened within first 4 days of surgery. Because at time, most of the time we are worried about bleeding rather than thrombosis. And it is associated with age, operational time, BMI, surgical position, use of perioperative intermittent pneumatic compression devices. And the last point is very important, and we need to remember that. At the same time, we have to differentiate other causes of hypoxia from PE, like atelectasis, pleural effusion, and respiratory infection in the postoperative patient, which are much more common compared to PE. Now, if you look at the clinical examinations, signs symptoms of respiratory system like dyspnea, pleural pain, cough, tachypnea, rales are not that specific or sensitive, and it doesn't contribute much to our clinical diagnosis. Even if we go deep and look at the hypoxia and the type of hypoxia like shunting causing increased alveolar arterial oxygen gradient, it's also not that much contributed. But if we try to elaborate or find the symptoms of DVT like cuff and thigh swelling and cuff and thigh pain, it may be much more helpful to at least raise the concern of PE. And when we are doing the clinical assessment, we have to confirm those findings of DVT. And at the same time, we should try to identify the clinical findings suggestive of RV dysfunction or RV strain like increased P2, right ventricular lift, and jugular venous distension. But again, I like to emphasize that silent pulmonary embolism is a significant entity. This meta-analysis done on 28 studies involving more than 5,000 patients where they have actively searched for pulmonary embolism either by CTPA or conventional pulmonary angiography or by lung scan has shown that in one-third cases of deep vein thrombosis, there are evidence of silent pulmonary embolism. And silent pulmonary embolism is more common in proximal venous thrombosis, and it also leads to recurrent pulmonary embolism because these patients are not identified and not treated. And because they're silent, that does not mean they're all small embolism. They may involve the central pulmonary artery also. Hypoxia, though, doesn't have diagnostic role, it has a prognostic significance. About 75% of the patients usually present with hypoxia with widened alveolar arterial gradient of oxygen. If they are tachypneic, the respiratory alkalosis and hypocapnia can be there, but hypercapnia, respiratory and lactic acidosis are uncommon. Hypoxia, as I mentioned, has significant prognostic role. Patients who present with hypoxia has a higher mortality compared to patient who does not require oxygen in the initial period. So, because of these non-specific clinical signs and symptoms, we need to have a very high index of suspicion while thinking about PE in appropriate clinical context. So, what are the investigations by which you can confirm? The gold standard is CTPA. If it is not available or cannot be done because of some reason, we can go for conventional angiography and sometimes lung VQ scan. Now, if the patient is really sick and we cannot ship them patient from out of ICU, then sometime in appropriate clinical context, lower limb venous Doppler and echocardiography can help to diagnose a clinically significant PE. So every test has its advantage and disadvantage. CTPA though has an excellent accuracy. It has issues related to iodine exposure, and the radiation effect is also very high. Pulmonary angiography, which was a historical gold standard, also has a very high radiation. On the other hand, the vacuum mismatch, which almost have no contraindication and has a very low radiation exposure, the inter-observer variability in interpretation is very high, and as a result, it was reported as likelihood ratio. So all tests has its advantage and disadvantage. Because of that, the role of pretext probability will come. So we have to identify the patients where the chances of having a PE is high, and accordingly we should go for further invasive tests. We all are aware of Wells score and revised Geneva score. And one of the most important points for Wells score is the clinical signs symptoms of DVT, that part we have discussed. And also when the P is most likely diagnosis. That's why we need a very high index of suspicion to diagnose PE. And if you look at our subgroup of patients, those already have a surgery and also have an active malignancy. So our subgroup of patients eventually come into the intermediate group. And when we compare the revised Geneva score along with Wells score, and they have a similar sensitivity in type of diagnosis or assessing the pulmonary embolism. So you can use both of the tests in your clinical practice. But what about the clinical assessment of the clinicians? If they decide not to go with any structured pretext, studies have shown that compared to a validated machine-based method, clinicians consistently overestimate pretest probability of pulmonary embolism. So the receiver operative curve is comparable. It has been also shown in meta-analysis that though the sensitivity of clinical assessment is high, the specificity is poor. So how can we increase the negative predictive value of this test further? We can include D-dimer in our protocol. Now D-dimer are small molecules. It comes into the circulation where there is a clot lysis. It happens most commonly in DIC, and it also increases in patients with PE. Cochrane review involving 4 studies with more than 1,500 patients and without any high-risk bias has shown that while excluding the diagnosis of pulmonary embolism, D-dimer has a sensitivity of 80 to 100%, but has a poor specificity. So a negative D-dimer test is valuable in ruling out PE in patients with low pretest probability. But it has a less utility in older population because routinely they have a higher D-dimer. But do all patients need D-dimer? Here the role of pulmonary embolism rule-out criteria will come. It is applicable only in patients with low probability and a low GESL probability of PE. It has 8 rules, 8 criteria. If all are negative, patient is very unlikely to have a PE. And so it shows that without increasing the incidence of thromboembolic events, it can significantly decrease the chest scan and also the length in emergency stay. As we already mentioned, the present D-dimer cutoff of 500 is not suitable for the elderly patient. For them, we need to get an age-adjusted D-dimer. Conventional rule is age multiplied by 10. And studies shown that if we go by the new age-adjusted D-dimer criteria, it also helps to decrease the number of radiological scanning without increasing the incidence of CTPA. But again, we are talking about low probability patients. Our patients already has an intermediate probability. Can we have a D-dimer cutoff adjusted for clinical probability? Yes, studies have shown that if we change our D-dimer criteria according to clinical probability, we can use it even in intermediate patients. So intermediate subgroup of patients, we have a cutoff of 500, and low pretest probability, we have a cutoff of 1,000. And studies done on more than 2,000 patients who have an initial diagnosis of PE around 7% has shown that only 1 patient has developed PE in the follow-up of 3 months, but it has decreased the usage of chest imaging from 50% to 35%, which is a significant number. There's another biochemical molecule which increases in PE. There is an attributic peptides. It includes ANP, BNP, and NT-proBNP. Though it doesn't have a diagnostic role, but in patients who has undergone VQ scan, if we have a statistically significant high value of these attributic peptides, it gives a higher probability of PE. And it also has a very significant prognostic role. It is a higher level is available in non-survivors. Among these 3, BNP has the highest prognostic role with a cutoff of 1.25. It has the best sensitivity and specificity. As I already mentioned, it has a significant role in prognostication, but its role in diagnosis fatal P or recurrent P or in the decision making of thrombolysis is not well evident, and we don't have enough data to make a comment on that. And what about right ventricular dysfunction? In an appropriate clinical context, right ventricular dysfunction can diagnose pulmonary embolism. So what happened because of obstruction in the pulmonary circulation? There is an increased RV afterload, causing RV dilatation, increased right ventricular tension. Eventually, it leads to poor RV contractility, decreased cardiac right ventricular output, followed by, because of intraventricular dependence, there is a ventricular failure, and eventually leads to an obstructive shock if not interrupted. What are the echocardiological findings? There will be enlarged right ventricle, dilated RV with basal RV by LV ratio more than 1, flattened intraventricular septum, distended inferior vena cava with diminished inspiratory collapsibility. There are some other findings which is not routinely available, like 60-60 sign, mobile thrombus into the right heart, decreased TAPSE, and decreased systolic velocity of the tricuspid annulus. We need a higher echocardiography skill to pick this up. So how to approach suspected PE patient without hemodynamic instability? We should go for the clinical probability. If there is a lower intermediate probability, we can go for the D-dimer. If it is negative, it rules out PE. If the D-dimer is positive, we should go for CTPA to confirm the diagnosis. On the other hand, if the patient has a high clinical probability, we should straightly go to CTPA. On the other hand, if the patient is hemodynamically unstable and could not be shifted for a CTPA on the first hand, we should go for an echo. If there is no RV dysfunction, it rules out P as the cause of hemodynamic instability. P may be there, but it is not that significant to cause hemodynamic instability. But if there is an RV dysfunction, we should review for access to CTPA. And if CTPA could not be done, we should search for DVT by lower limb venous Doppler. And if CTPA can be done, we should go for CTPA. In terms of supportive care, respiratory support will be as per our standard practice, like oxygen by nasal cannula, face mask, or HFNC. And if that doesn't work, then we can consider for NIV or mechanical ventilation. On the other hand, supporting right ventricle will be very little tricky in terms of hemodynamics. We have to give cautious fluid very cautiously, because if there is an RV distension, it may worsen the clinical scenario. The noradrenal will be the vasopressor of choice, and if the RV systolic function is very poor, we can consider for dobutamine. And if all this fails, as a rescue measure, we can consider for veno-arterial ECMO. Now, can we assess the severity of pulmonary embolism? Yes, there is a scoring system which is called Pulmonary Embolism Severity Index. The original score was a little complicated. There's a simplified version which has 5 points risk factor and all has 1 point. If the score is 0, the 30-day mortality is 1%. The score is 1 or more, it increases by 10%. There are other clinical findings which also influences severity and the risk of mortality in hospital. Those are hemodynamic instability, RV dysfunction in echo, and elevated cardiac troponin level. So if all these risk factors are there, patient has a higher chance of mortality and eventually poor outcome. So what are the treatment options? Once there is a documented P or high suspicion of P, we need to anticoagulate. If the patient is hemodynamically unstable, then it becomes a high risk, and we need to consider for reperfusion treatment. On the other hand, if the patient is hemodynamically stable, we should look for severity of the P and look for RV dysfunction. If these are present, then we should go for troponin level. If the troponin is high, then it becomes an intermediate high risk, and we have to keep them under strict monitoring and may consider for a rescue reperfusion. If it is negative, they just need anticoagulation. So what are the indications of thrombolysis? High-risk patients with hemodynamic instability, and there are other potential indications like patients with severe right ventricular dysfunction, severe hypoxia, acute P, who are on the verge of decompensation because of poor reserve, and extensive clot burden. The options for thrombolysis are RTP and streptokinase and urokinase, but in our subgroup of patients, the scope of systemic thrombolysis is very, very less, and it's unlikely to be possible also. So whenever we are giving empirical therapy, we need to be reminded about the risk of benefit, the risk of bleeding we have to consider, and there are some risk factors which make a patient more prone to bleed, and probably our patients are along with the high risk of thrombus, there will also be high risk for bleeding also, because the age, previous underlying malignancy, metastatic cancer, comorbidity, recent surgery, all are very high risk factors. So in our group, probably anticoagulation with unfractionated heparin is better option after a weight-based bolus injection, because they can titrate it, and because if the risk of bleeding is high, you can titrate a lower APTT, maybe 1.5 times to 2 of the normal value. And once the patient is stable, bleeding risk is less, we can change it to LMWH. Systemic thrombolysis is not an option, but there may be scope for surgical pulmonary embolectomy or percutaneous catheter-directed treatment. And if things doesn't work, and for the supportive care, we may need to escalate to ECMO. Follow-up. This patient definitely need follow-up, because depending on the underlying cause and the risk factor, different patient has different probability of recurrence. So when the patient has a routine surgery with some under general anesthesia, maybe the chance of estimated long-term recurrence is low. But if the patient has an active cancer, like our subgroup, past history of DVT, or any scope or a chance of antiphospholipid antibody syndrome, they have a very high chance of recurrence. So they need to be monitored, and we have to decide regarding the duration of anticoagulation in this subgroup of patients. So to conclude, postoperative PE is not a myth, it's a documented entity, and we need to have a very high index of suspicion to diagnose it, because most of the clinical findings are very non-specific and does not help to rule out, differentiate from other respiratory symptoms. So a protocolized approach in your unit need to be there to identify them. And whenever we are giving empirical anticoagulation, we need to consider the risk of bleeding and have to optimize it. So eventually the therapy in a post-op patient will have to be individualized, making a balance between the treatment of PE and the risk of bleeding. By this, I'd like to conclude my presentation. Thank you for the opportunity.